Good afternoon, everyone. My paper is on IgG4 related ophthalmic disease, an observational case series from a tertiary eye center in Kerala. IgG4 related disease is an idiopathic multi organ inflammatory state. It manifests as chronic, relapsing, sclerosing inflammation in any organ system. Pathogenesis is thought to revolve around humoral and cell mediated immunity. Pancreas and salivary glands are the most commonly affected organs, and ophthalmic manifestations of IgG4 related disease can be varied, most commonly affecting the lacrimal gland. To characterize the ophthalmic manifestations of IgG4 related disease, the aim and objectives of the study is to characterize the ophthalmic manifestations of IgG4 related disease and to study the disease response. Materials and methods. It's a retrospective case series done at a tertiary eye center in Kerala. 5 patients were studied in a span of 2 years, and all patients who presented with IgG4 related disease, ophthalmic disease, were included in the study. A detailed clinical history was taken, uncorrected and best corrected visual acuity and extraocular movements recorded, slit lamp examination and fundus examination were done, and IOP readings were taken. Detailed examination of the orbit was done, magnetic resonance imaging was done, incisional or excisional biopsy taken, which was sent for histopathology and immunohistochemistry, and biochemical tests were also done. Patients who were positive for IgG4 related disease were sent for rheumatology consultation and were started or on oral steroids and immunosuppressants after ruling out a systemic disease. Results and discussion. General characteristics. Out of the 5 patients studied, only 4 were female. The mean age at presentation was 40.2 plus or minus 15.43 years. The clinical characteristics. The presenting complaints were prominence of eye in 80%, lid edema in 40%, and double vision in 60%. In our study, only one patient had bilateral presentation, and visual acuity impairment was present in one patient. The most common organs involved were lacrimal gland, followed by extraocular muscles and soft tissue. None of our patients had extraorbital manifestations. Serum IgG4 was done in 4 patients and was found to be raised in all the 4 patients. C-ANCA was positive in 1 patient. CRP was positive raised in 1 patient, and serum ACE levels was raised in 1 patient. There was rapid progression of signs in 1 patient, resulting in profound visual acuity impairment. Imaging showed involvement of lacrimal gland, extraocular muscles, and orbital soft tissue, and lacrimal sac. Figure A is a T2 weighted MRI showing solid mass in the inframedial quadrant of the right orbit with involvement of the lacrimal sac and extraocular muscles. And figure 2 is a T1 weighted MRI post contrast showing a solid enhancing lesion in the inframedial part of the right orbit with involvement of the inferior rectus and the medial rectus. Management, incision or excisional biopsy were taken and sent for histopathology examination. Pathological findings. HPE analysis were available in all the 5 patients, and the most prominent features were lymphoplasmacytic infiltrate, eosinophilic infiltrate, storiform fibrosis, and perivascular inflammation. IHC for IgG4 positive plasma cells was performed in all the cases and were consistent with IgG4 related disease. CD3 and CD20 markers were also positive. According to the diagnostic criteria for immunoglobulin G4 related ophthalmic disease, 4 patients were classified into definite category and 1 patient was classified into probable IgG4 related ophthalmic disease. Treatment and response. Treatment was started with oral prednisolone, mycophenolate mofetil, azathioprine, and methotrexate. The mean follow-up period is 9.4 months, and only 1 out of the 5 patients were reported to have recurrence. IgG4 related orbital inflammation. The most common presentation was painless eyelid or periocular swelling and proptosis. The order of involvement: lacrimal gland, followed by orbital soft tissue, extraocular muscles, eyelid, optic nerve, and the trigeminal nerve. Inflammation and fibrosis are the key components in the pathogenesis, and there is an increased risk for lymphoma in patients with IgG4 related orbital inflammation. The various treatment modalities available are oral steroids, which is the first line of management, intraorbital cortical steroids, immunosuppressive agents like azathioprine, methotrexate, and mycophenolate mofetil. Rituximab, which is a monoclonal antibody against CD20, is a promising treatment in IgG4 related ophthalmic disease. This is a comparison of various studies in this topic. In a study by Michael Lebo et al., 19 patients were studied in a span of 8 years, and 57.9% were found to have bilateral disease. Lacrimal gland was the most commonly involved organ. Serum IgG4 was elevated in 61.1%, 78.9% had a systemic disease, and disease relapse was found in 66.7%. In a study by Sato et al., 57% had bilateral disease. Lacrimal gland was the most commonly affected organ. 10 patients had elevated IgG4, and systemic disease was found in 29%. And disease relapse was present in 28%. This was consistent with the result of our study. So the conclusion, what we knew before the study was the characteristics of orbital inflammatory diseases, and what we wanted to know with the study was the characteristics of IgG4 related orbital disease, variable presentations, treatment and response. And what we learned was IgG4 related ophthalmic disease is a chronic painless subset of orbital inflammation. HP is crucial in correct diagnosis, long-term follow-up is required, and prompt and accurate diagnosis ensures a good prognosis. These are the references. Thank you.
Good, FIDHA. I just wanted to ask you, do you routinely test IgG4 in all orbital inflammatory diseases? Or was there anything which made you suspect this and, and ask for
The first patient was having a painless inflammation in the orbit. So we did a biopsy and confirmed with this. And all other patients now when they come with this like fibrosing kind of inflammation, which is painless, we usually suspect this and do biopsy.
Which is a fibrosing inflammation. Two of your patients had other tests positive. One had a elevated serum ACE and the other one had a C anchor positive, which is considered to be very specific for GPA.
Yes, ma'am.
So why did you decide, it's not an GPA, and, go for IgG4 diet?
As it was HV proven and immunohistochemistry was positive for IgG4 plus cells. So we took that as a diagnosis.
In your study, the patients were much younger than any of the other studies. And also they presented much earlier than the other studies. Any reason why? No. Where were the other studies from? You did mention some studies, but where were they done?
One was a French case series.
Okay.
One is a Japanese series, and there is a Chinese series.
Okay, so then the conclusion is that good eye care is easily available here, and people avail it much faster than those undeveloped countries, maybe. Huh? Okay, thank you.
Thank you.